So as Professor Froelich said, I'm going to talk about the internal carotid artery and its course through the cranium. And a lot of this work was done in collaboration with others. I think it's most important to recognize for many of us, at least I'll speak for myself, that much of what you do is attributable to your colleagues, to others who work with you and collaborate. It's what makes it interesting and fun, but it also makes it productive. So I would recognize those who have assisted me. Drs. Theodosopoulos and Zimmer are in the audience. Dr. Froelich is obviously in the audience. Dr. Helen Sabula is a resident. She's currently in Paris, but she came to the United States and spent 6 months with us and did some work which we're going to present later. So first of all, I think it's necessary, why should a neuroanatomist be speaking to a group of neurosurgeons? So I chose this illustration. It's a Rembrandt from the 17th century, and it's called The Anatomy Lesson of Dr. Tulp. And the quotation that I have is not from Rembrandt, but rather from William Hunter. And throughout this presentation, I will diverge and present some history. I think it's important to know from whence we came, and paying attention to history has some value. And William Hunter, one of the great Hunter brothers, made a statement, were I to place a man of proper talents in the most direct road for becoming truly great in this profession, I would choose a good practical anatomist and put him into a large hospital to attend the sick and dissect the dead. So I'm going to hold on to that. I'm going to lose a sense of humility and say, maybe I'm one of these anatomists that can serve in this capacity. William Hunter came to London in 1740, and his brother followed him 10 years later. And his brother, John Hunter, was one of the most famous surgeons, anatomists, philosophers, etc. And one should acquaint himself or herself with some of the literature about Hunter, because you'll be amazed at his breadth of knowledge and interest. And I'll make one digression. He built a museum, which is now the Hunterian Museum, and he spent a considerable amount of his career collecting all kinds of models and specimens, etc. And one of them was a pituitary giant. There was a gentleman from Ireland who came to Europe, and then he came in contact with John Hunter, and Hunter recognized this as a rare specimen and a specimen of true interest to him. So he followed him around London, or had people follow him around London, and Hunter knew, he was a clinician, that this was a pituitary giant. He had cardiomyopathy. He wasn't long for this world, and Hunter was right. The gentleman died at the age of 22, and prior to his death, he had paid friends of his and an undertaker to make sure that his body was kept out of the hands of John Hunter. And he also purchased a leaded casket, which he had paid for to be brought out to the middle of the English Channel and dropped into the English Channel, so Hunter had no access to his body. Unfortunately, he did not figure that Hunter was much more cunning than that. He paid the undertaker a substantial amount of money, 500 pounds, much more than the undertaker was paid by the pituitary giantess friends. So Hunter gained access to the body, brought it back, drove across London, brought it to his house. He worked on it and became the frontispiece of his museum. So he was a driven human being as well. So we're going to talk about the internal carotid artery. We're going to do a little bit of historical perspective. As I said, I want to emphasize some of the history. We're going to look at the embryology, albeit briefly. I think we are obligated to at least refresh ourselves about the internal carotid artery. We're going to look at segmentation, which has been one of our interests in Cincinnati, segmentation from an anterolateral approach, from a typical intracranial surgical approach. and then from an endoscopic approach. And we're going to talk about perspective, and this is anatomical perspective. So if I talk about history, I'm obligated to present one of my heroes in history, and this is Thomas Willis. And Willis lived in the 17th century in England, in London. He was probably one of the most famous physicians at that time. He was a physician. He was an anatomist. He was a scholar and a naturalist, so he had a breadth of knowledge. And he wrote a book on the anatomy of the brain. And in that book, he talked about segmentation of the internal carotid artery. And this is his illustration taken from his book. And he assigns 4 segments to the internal carotid artery. Obviously, the extracranial, the cervical carotid, and then he talks about the petrous segment, and he then talks about the intracranial as it goes from the petrous bone through the cavernous sinus and then becomes intracranial and intradural. And I'll document later that he did understand intracranial, intradural presentation of the internal carotid artery. Now, Willis wasn't the first to look at the internal carotid artery, and I could go back and pick other anatomists and physicians who had looked at it, but I chose to start with Willis. And in the embryology, I think we have to look at, this is Walter Dandy. So I think all of you know Walter Dandy. He was a well-known American neurosurgeon, but I think known throughout the world. And Walter Dandy hired this Dorcas Hager Paget. She was a medical illustrator at Johns Hopkins, where Dandy was on the faculty. And Dandy hired her and paid her personally to be his medical illustrator. And then in the 40s, he charged her with, he was writing a book on cerebral aneurysms, and he was interested in the cerebral vasculature. So he charged her with developing a study to appreciate and understand the development of the arterial and venous anatomy of the cranium, and which she took the charge seriously. And then in 1946, unfortunately, Dr. Dandy died, and Dorcas Hager Paget continued her work on the embryology of the internal carotid artery. In this case, she also did the venous anatomy. And in 1948, she wrote The Development of the Cranial Arteries in the Human Embryo. If you are not familiar with this, I think it is a mandatory read for all of those interested in cerebral vasculature. It is, at the same time, a very, very painful read. But nonetheless, I think if you can bear with it and go through it, you will have the information, because nobody really looks at this anymore. And so it's a great piece of literature. And these are just illustrations just to document. She looked at stages of development in the human embryo. We're not going to go through that. We're interested primarily in the internal carotid artery. And we know that the internal carotid artery comes from the third branchial arch. You remember that from medical school. And it moves toward the head end. And since I know that I was going to be here in Strasbourg, rather than go to the American literature, I went to the French literature, and De Vries in 1905 worked on the embryology of the human. And at the same time, this was going on in the United States. But the work is very similar. De Vries was credited with looking at the internal carotid artery developing, and as it moved to the cranium, he defined 2 portions, a cranial portion and a caudal portion. The cranial portion continued to go around the optic vesicle. It contributed what is a primitive ophthalmic artery eventually to become an ophthalmic artery. He talked about a primitive maxillary artery. And then as it came around, it came all the way to the olfactory region of the embryo. And then there was a caudal portion, and the caudal portion became ultimately the posterior communicating artery. But we're only going to talk about the internal carotid artery, so it's a third branchial arch derivative. And all the details can be found in this reference that I've made. And so in the 80s, this is the scanning electron microscope, to say it's a quantum leap from looking at the embryology with histological sections. Here's the truncus arteriosus, and here is derivatives of the third branchial arch, the common carotids coming out at you. This is the third, so this would be the fourth branchial arch. Remember, there's no fifth, but they're 1 through 6. Fifth is atretic. And here you can see it here going on to the cranium. So that ends our embryology, but I wanted to bring it to your attention so you don't dismiss it. And then if I want to talk about segmentation, because that's one of our interests, and we said already that Thomas Willis talked about 4 segments of the internal carotid artery. There's another famous paper in 1938 done by Fisher. Fisher was a radiologist. He was not a neurosurgeon. He was not a neurologist. And he wasn't interested in segmentation of the internal carotid artery. And I found this article almost in defense of myself. I did not know, but I kept hearing neuroradiologists in particular talking about the C1 through C5 segments of the internal carotid artery. Has anybody heard of those segments? That's just a yes or no. You can. Well, everybody that I talked to was talking to me about the C1 through C5. And this is something that I've learned through my career, maybe the hard way. But as you begin to ask people questions, if they become annoyed at you, it's often because they don't know the answer. So rather than tell you they don't know the answer, they try to dismiss you or get rid of you. And they say, it's inherently obvious, you ought to know. So I went back and I looked at Fisher's article, which was 1938, written in German. That was another painful process. But I would say never read a book about a book. You need to read the book. And if you looked at Fisher's work, he was talking about these segments, C1, 2, 3, 4, and 5. But he started intracranially with C1 and 2, and then C3 was intracranial, extradural. And he was interested in how the internal carotid artery changed its position, whether it was opened or closed, based on tumors, primarily tumors, intracranial tumors. And he had no interest in, again, I say the segmentation, but it was this C1 through 5 that became the accepted terminology for people discussing various segments of the internal carotid artery. And if you look at it more, I was invited once to speak, and I was at the University of Arkansas, and I was talking about segmentation of the internal carotid artery, and Dr. Yassergill was in the audience, and he asked me if I knew about his paper, because he too had written, as he's written almost on everything, cranially based. He had a segmentation system of the internal carotid artery based on histological examination of the carotid, and he found 12 segments of the internal carotid artery. And he asked me again if I was aware of it, and I said I was aware of it. I had made a fatal error. I didn't have this slide with me at the time. And then he said, why did you not show it? And I said, because histological definitions will not serve the neurosurgeon. You're not going to be able to see the histology of that artery at that time to know which segment of it was. That did not sit well with Dr. Yassergill, but it happened to be the truth. And then another well-known name in neurosurgery is Dr. Taka Fukushima. And like many things, he named another segment, the C6 segment, or the Fukushima segment. And he was recognizing Fisher's original work from 1938, and he wanted to include, he was doing it not anterograde, but retrograde, and adding this C6 segment. And then Dr. Roten, who has touched almost every area of cranial anatomy, talked about, this was an article by Guibault and Roten, but they talked about 4 segments, again, going back almost to Willis's classical work, and the cervical, petrous, cavernous, and then an intracranial. And that's the terminology that's used in a monograph called Nomina Anatomica, which is the official nomenclature for use in medicine. And then in 1996, we looked at segments of the internal carotid artery, and we assigned 7 segments to the internal carotid artery, and we published this in 1996 in the journal in Neurosurgery. And this was our segmentation. C1 was the cervical, 2 was petrous, 3 is the lacerum. We'll talk about that. 4 is cavernous, 5 is clinoid, C6 is ophthalmic, and 7 is communicating, posterior communicating. And so this was Fisher, Guibault, and this is Lajunius. Lajunius had 6 segments. He was saying that each of these was a different embryological origin. I'm not certain that that's correct, but nonetheless, he had looked at this as well. And when I thought that I was correct, and we published this, I found subsequently, maybe 15 years later, that Lazortes in 1961 had also looked at segmentation of the internal carotid artery, and he did all the way through C6. All we did was add 7, but I have to say I was unaware of his work, and I confess I should have looked at the literature more diligently, and that I only say as a responsibility for all of us to be very careful. If you think you've discovered something new, in all likelihood it's not new. In all likelihood someone else has done it, and so you need to be cautious. Never say, this is the first paper. You say, or you say, to the best of my knowledge, which in my case is minimal, but nonetheless I stand corrected and give credit at least to Lazortes for his work in 1961. So again, here are our segments of the internal carotid artery as we see them. This is from an anterolateral approach. The intracranial ICA is seen from that intracranial anterolateral surgical approach. And if we look at the first 2, we can look, we're interested right at the C1-2 where you have transition from the cervical to the petrous segment at that C1-2 level. And we also looked at segments of the internal carotid, and we found that the most distal of the extracranial ICA, that 11 plus millimeters, is relatively inaccessible at that time from an extracranial perspective. So that was our C1-2. And we looked at it also, so we can see here's the internal carotid artery coming into the cranium, and here this lateral edge of bone is the vaginal process of this piece of bone, and you can see the sheath has both a canal portion going along the carotid canal and one on the extracranial skull, or the exocranial surface of the skull. And this is probably our most interesting area. It's the one that you would be interested in as well, because these are the cranial parts that you're most familiar with. And if we start caudally, here you can see the auditory tube. You can see the region of the foramen lacerum. So this is more posterior. This is a cross-section of the bone. And here we're at the level of the, as I said, the foramen lacerum. Here you see laterally, you see the region of the cavernous sinus and the internal carotid artery, the trigeminal ganglion lateral. Here's the mandibular division of V3, and just medial to it is the otic ganglion, which you infrequently would see. And here it is from an exocranial perspective. Here is the foramen lacerum, but in the human, the foramen lacerum has a cartilaginous plug. But there are on occasions dehiscence, and that carotid is pouching or poking through and obviously would be vulnerable for an anterior approach. And as we move forward, we go from the lastrum segment to the cavernous carotid, the C4, and we know that there are major branches that come off the carotid in this region, the meningohypophyseal. There are 3 major branches, the inferolateral. There are 4 branches there, very important for vascularization of the cranial nerves. And then there's the McConnell's capsular artery, which is, according to Dr. Roten, maybe 10% of the time present. The meningohypophyseal, he says, is 100%. And then the inferolateral, which is about 80% present. And as we look at this, I show this bony anatomy. Why is this important for vascular anatomy? Because we're going to see we have to pay attention to some of this sphenoid bone here. You're looking from the endocranial surface. You're looking down on it. What's probably most important here is not only the optic strut, which you looked at yesterday, the inferior root of the optic strut. Remember, there's a superior root and an inferior root. Here you can drill out this optic strut, but right here you have a bony connection. So this, number 2, is a carotidoclinoid foramen. And that has a bony or an ossification, circumferential going around the internal carotid artery, and it anchors that internal carotid artery. If you're doing an anterior clinoidectomy and you have resistance, you have to be careful and be cautious and knowledgeable that this carotidoclinoid foramen can occur. We found it. We looked at 145 skulls. It occurred in 13% bilaterally. And it occurred in another, up to 32% of the skulls that we looked at had either a complete or a partial carotidoclinoid foramen. So I think that's a significant figure. Now, what you do with that, and maybe it isn't as critical as it seems, but I think you have to look at it. If you pull on the carotid too aggressively, you can tear the carotid, and then you have a bigger problem than you would like. And here you can see the middle clinoid process. You can almost always find a middle clinoid process. Sometimes it's minuscule, sometimes it's very prominent. And as we move forward, we're just moving forward in these coronal sections. You can see the internal carotid artery. Here we see the cavernous clinoid and supraclinoid segment. You can see the second cranial nerve. Here you can see the distal dural ring, and these are important structures. And then finally, here you have the anteroclinoid process. You have the carotid. Here the carotid is cavernous. Here it is supraclinoid, so it's intracranial and intradural. And you can see its relationship here. Here's the pituitary gland. Here's the medial wall of the pituitary. We talked about the medial wall yesterday. The medial wall can be somewhat tenacious or tough. It can be fenestrated. It can be almost non-existent. And certainly pituitary adenomas will follow paths of least resistance, and they can clearly access the medial cavernous sinus, particularly if there's a fenestrated or almost non-existent medial wall. And in a dissection, here again we see the intracranial, intradural, ICA, the ophthalmic artery. This is obviously the lateral section. Here's the proximal dural ring, and here is the, right in this area, you're going to have the distal dural ring. This proximal can be tough and tenacious or non-existent also, and in this case you can see venous channels moving through, so it's an incompetent proximal ring, and you can have the venous, the vessels going all the way up to the distal dural ring. And looking now down on top, the other branches that we would mention, you have the superior hypophyseal arteries. We counted from 1 to 4, lots of variation there, and we see a carotid cave. Kobayashi described that carotid cave in 1989. A carotid cave exists in about 70% of specimens. So again, I think it's important to appreciate. It's also, if you have a carotid cave, you can also have aneurysms within that carotid cave. And finally, on a sagittal, you can see the distal dural ring right here. The ophthalmic artery arises just distal to the distal dural ring in 90% of the cases. In 10%, it's proximal. It can arise from the clinoid segment or from the cavernous segment. And I show this to just point out if you're doing a clinoidectomy, if you're too aggressive, if you move medially, you're into the sphenoid sinus. And on the reverse side here, you see the opticocarotid recess, and above you see the optic nerve and the ophthalmic artery. This is what? It's a transitional aneurysm. You see this neck where the arrow is pointing around this aneurysm. If you cut the distal dural ring, you will free up the aneurysm, and it will be a transitional aneurysm. It'll be above and below that clinoid process. And I bring this to your attention. This is from Willis's book, 1664. He's talking about the artery. He's talking about the course of the internal carotid artery in the cranium. And he says it goes on till it comes to the head of the turkey chair. That's the sella turcica, where again, being bent in and intorted with a certain compass, it ascends straight and boring through the dura mater is carried toward the brain. Boring through the dura mater, I would offer to you, is the distal dural ring. So in 1664, he had, in fact, described the distal dural ring. He didn't use that same terminology, but I would ask anybody to tell me, no, that's not the case. So I think he clearly knew what he was looking at, and he described it exquisitely. So now it's also important to have perspective. We've looked at the carotid from the intracranial perspective, from the intracranial surgeon's perspective. But I think we have to look at this sphenoid bone, and we have to look at it in various perspectives. I call this faces of the sphenoid bone. You're usually looking at the sphenoid bone, at least neurosurgeons are looking at it from an intracranial perspective, so you're looking at that endocranial surface. But the ENT look at it also from the exocranial surface. And I think we have to be familiar with both. And taken from Capobianca, opposite to what one thinks, the nature of anatomy is unpredictable. It changes with the perspective and direction of viewing a specific structure, the level of magnification, and possible anatomical variations of landmark reference points. Anatomical conundrums during surgery can humble the most talented surgeon. And I think this is very applicable to endoscopic anatomy because it's a totally different perspective for many, not necessarily all ENT, but for many neurosurgeons it's unfamiliar territory. And this is a slide taken from the Pittsburgh group, and I have permission to use the slide. We look at this structure. Here we're looking now at the endoscopic perspective, and again we see the carotid prominence, the ICA, the optic nerves, the tuberculum cellar recess, the cella itself and the clivus, and the opticocarotid recess, and also the middle clinoid recess. And from a sagittal section here, you can see this is the chiasmatic sulcus, this is the limbus sphenoidal, and the tuberculum cella here. And it's really called the prechiasmatic sulcus because more often than not, the chiasm doesn't sit in the prechiasmatic sulcus. Therefore, how it bears its name is the prechiasmatic sulcus. And here you see a fortuitous section of the pituitary showing the adeno and neurohypophysis in the posterior clinoid, and here the ventricular system and the optic nerves. So we're looking at this. Here we see the sellar face, and here we see the planum sphenoidal. So when we're going to talk tomorrow about transsphenoidal, endoscopic transsphenoidals, that's what you're looking at. Those are the expanded areas where you can go. And these are just some dissections to show an expanded and its relationship. Here you see the circular sinus of the around the carotid, and remember there's an upper and a lower circular sinus. So we also became interested since we did the segmentation of the ICA from the anterolateral perspective. We said intracranially versus endonasal perspective. Why develop a new terminology for the ICA? There are numbers, segments, loops, Janus, and bends. And all of this, perhaps, is what Winston Churchill ascribed as terminological inexactitude. I think it's very important to have a language that can be used to communicate with one another in the same discipline and clearly communicate with others in other disciplines. So there's a common language and you know what each is referring to. And again, going from Capobianchi, it changes with perspective and direction of viewing a specific structure. So I would offer that if you look at the internal carotid artery anterolaterally, we have certain segments and we have lines of demarcation. Why would those change if you looked at it endoscopically? I don't really think they would or should. And we looked at this, and we first looked at the literature, and if you see, and I'm only picking a few, Herzala and Cassiano from the University of Miami have a nomenclature that they assigned to the endoscopic ICA, and it's very complicated, as did Alfieri and Dr. Joe. Again, they developed a whole new terminology to describe the ICA as seen from the endoscopic perspective. I'm not saying they're incorrect, but I think that their numbering system is so confusing, and they have Janus, they have numbers, they have segments. It's all over the map. So we decided, can we look at this system and see if we can apply our same terminology that we did for the anterolateral? I borrowed this from Dr. De Bruyn and his colleagues. This is purely the cavernous ICA. He had a posterior ascending and an anterior ascending segment. This work was done at looking at carotid fistulas, carotid sinus fistulas, and here is where he looked at 54 cases, and this is the distribution of where these fistulas were found along the cavernous carotid. But we borrowed his posterior and anterior ascending segments for our terminology, and we look at that here in a lateral view, and on your right, an AP view, and we have assigned certain bends to the internal carotid artery. Originally, we talked about loops of the internal carotid artery. Loops came from Vinco de Lenz's work, but we used loops initially when we were writing this, but a loop is something that comes up and goes around and back out in the same direction. And the carotid, in this case, doesn't do this. So we have abandoned loops and gone to say that there are bends. And we've defined 4 bends. A C2 bend, a C3, 4, a C2, C3, 4, C4, and a C5, 6 bend. So we have 4 bends in our system. This is from the endoscopic perspective. And then if we look at it, here we see the C4. So this is the posterior ascending portion of it, and here's the horizontal portion of it. And you see its relationship to the opticocarotid recess and the proximal aspect of the distal dural ring, of the dural ring. Our C3, this is our lacerum segment. And the lacerum segment is marked by the petrolingual ligament. And even though you don't see the petrolingual ligament, when you have this region right here, you know you're essentially looking at the petrolingual ligament, but remember it's on the other side. And this is the posterior ascending segment. This part right here was called the paraclival ICA by the other people that I'd mentioned, and it always bothered me because there's nothing clival about the ICA. The clivus is in a totally different plane, and I think it was a perspective that made people call it the paraclival, and I would advocate that it not be called paraclival, but rather clivus, or rather it's the ascending, posterior ascending ICA. So this is our posterior ascending ICA. Here would be the lacerum segment, posterior ascending, the horizontal, and finally the anterior ascending segment of the ICA. And if we look at this, this is our anterolateral approach. In here, this coronal section. On the left, you have this endoscopic perspective. This is at the level of the foramen lacerum. And on your right, this is at the level of the sinus. You've opened the sinus to show the perspective all the way to the caudal orbit. So these are, again, our segments, and we think we can match them up point for point, 1 through 7. And finally, Dr. Sabula, who spent, again, I said 6 months in our laboratory, looked at the endonasal variability of the ICA. She looked at 20 cadaver heads, and we see various shapes of the ICA to when it's very tortuous to when it's relatively straight or sagittal. And one other type is the asymmetric, where it's different from side to side. So we defined 4 types. I don't think it's so important that there are those 4, but rather, if you look at how tortuous this is, it plays a role. And we also did measurements to see how close the carotids were to various portions of the pituitary. We're not going to go into that today. And we also measured the angle of the posterior ascending and the horizontal segment. So we had different angles. We can associate that. And this is what it looks like from an intracranial perspective. And now if we take our same model and we look at it, this is the sagittal plane, and this is a tortuous ICA. As that tortuous ICA moves from the sagittal, say more vertical, and bends out, it opens up that carotid, and it's potentially accessible, so you can access the posterior cavernous sinus using that route, because there's space in there to allow you to access the mesial aspect of that posterior cavernous sinus. So there is a closed window when you have, it's pretty much vertical, and an open window. And we would offer that this open window allows surgeons access to the cavernous sinus, particularly to the posterior cavernous sinus. And you could determine this preoperatively, potentially, so that you knew that you could approach this region. And finally, the shape of the space between the right and left posterior ascending segments of the ICA, and we define 2. We have a trapezoid and an hourglass. 80% of the cases were trapezoid, and only 20% were hourglasses. So, in closing, I would draw from another American surgeon, Samuel Gross. This is the Gross Clinic. It's a well-known image. You will have to learn many tedious things, which you will forget the moment you have passed your examination. But in anatomy, it is better to have learned and lost than to have never learned at all. And I would close with that and say this drawing, or this painting, was done by Thomas Eakins, a great American painter. He made $400 for this in the 1800s, about 1850 or 1860. It was just sold from Thomas Jefferson University. It was in the hall of the entryway into Thomas Jefferson Medical School, and it just sold for $143 million. And the medical community was outraged because they said, this is our symbol, how can you do this? And then the school came back to the faculty and members of the board and said, well, okay, we'll change our mind. If you can pay us $143 million, we'll keep it. It's now in a private museum. Thank you for your time and attention.